In this talk, we will cover the approach to chest pain in the emergency room. Chest pain is a very common problem, and a lot of patients would come with this particular complaint to the emergency room. And chest pain has a tendency to evoke some anxiety, both for the patient as well as the physician who is encountering it in an acute setting. Let's start with a couple of case vignettes and then see how we can solve some of the common problems or common questions which we encounter when we are dealing with a patient presenting with acute chest pain. The first case is that of a 56-year-old male who is a diabetic and a 25-pack-year smoker. He comes into the emergency room with vague, ill-defined, ill-localized chest uneasiness, sweating. He feels nauseated, and he feels it's probably related to indigestion. He has had similar complaints in the past when he is walking or doing some effort, but it always used to subside on resting, whereas today it's not yet subsided despite having taken rest. A question for you is, which of the following tests can help rule out an acute coronary syndrome in this patient? Is it A, an ECG, or is it an echocardiogram, a troponin level, a BNP level, or is it none of the above? While you think about this, let's look at another contrasting case scenario also related to a similar situation in the ER. This is related to a 20-year-old male, a college student, who is brought into the ER with a sharp left-sided chest pain. He says it's severe and it's worse on lying down. He's also unable to breathe freely because of the pain, and he feels that breathing worsens the chest pain. He also tells you that he's had some fever 2 days back. So related to this case vignette, I would like you to think about this question. Which of these features supports an acute coronary syndrome or an ACS as the likely source of chest pain? A, chest pain which is reduced on walking. Second, postural variation of chest pain. C, associated autonomic symptoms such as nausea and vomiting. Or is it D, pain radiating to the trapezius ridge? So these two cases serve to kind of illustrate some of the common questions which would crop up when we are dealing with a patient with chest pain in the emergency room. It accounts for approximately 10% of emergency room visits. And the main challenge which we are faced with in evaluating this patient is in basically discriminating life-threatening causes of chest pain, such as acute coronary syndrome, from non-threatening causes. But the important thing to keep in mind is always we need to consider the overall picture rather than a particular test in isolation. Some of the problems which we need to solve, or some of the questions which we need to answer in order to arrive at management decisions. Is this chest pain because of MI or acute coronary syndrome, which is probably the most life-threatening diagnosis in an acute situation? So how will you evaluate this patient? And then the important question as to whether the patient can be safely discharged home or does he need to be admitted? So when we are looking at chest pain, we need to think in terms of high-risk causes, low-risk causes, and those which are somewhere in between, or what we can call intermediate risk. Some of the important high-risk causes to consider, first of all, ACS or acute coronary syndrome, which consists of basically MI and unstable angina, then pulmonary embolism and aortic dissection. Some of the intermediate risk causes would include something like pneumonia or pleuritis, as well as pneumothorax. And potentially low-risk causes would include musculoskeletal causes, gastroesophageal reflux disease, and to some extent pericarditis. So in evaluating a patient who comes with undifferentiated chest pain to the emergency room, I would suggest that you have a three-pronged approach. Consider the pain, consider the background or consider the type of individual who's coming with these kind of symptoms, and consider the relevant investigations in support of the clinical picture which you have formed. So let's start with the first consideration, that is considering the type of pain or the type of history the patient is presenting with. One of the key questions which we need to answer, especially in trying to decide if it's acute coronary syndrome or not, is, does this pain represent angina? Just like you have the P, Q and R waves on the ECG, I would suggest you think about the PQR of chest pain. The most important among these, or central out of these, is the Q, or the quality of the chest pain. Flanking it on either sides, you have the P, or the precipitating factors, and R, the relieving factors of the chest pain. Anginal pain has been described with certain typical qualities. It is generally described as a pressing or a crushing kind of a chest pain. It is described as a heaviness, and sometimes it's also described as a burning. It's most often central rather than on the left side, and it's generally diffuse rather than being localized. So this is what we can kind of term the fist versus the finger. Many times patients with angina describe the sensation with a clenched fist over their chest wall, as opposed to being able to point to a specific spot on the chest with the help of a finger. So it tends to be more ill-localized, and in fact this phenomenon of the patient holding a clenched fist over the chest has been termed as the Levine sign. The other thing to remember about the quality of anginal pain is the characteristic radiation which it tends to have. It tends to radiate to certain specific sites, such as the arm, which could be either arms, the shoulders, or the jaw. Now, having talked about the typical sites, it's important to remember that there is a wide variation in this. And it has been seen that anginal pain can essentially radiate over a large area, essentially anywhere from the jaw right up to the umbilicus. So beyond these distributions, it becomes less likely to be anginal pain. So the other thing to remember is the presence of associated symptoms of autonomic arousal, such as sweating, extensive diaphoresis, nausea, a general sense of unease, and so forth. Another thing about angina is that generally it is not instantaneous or it's not peak at its onset, and generally it tends to build up to a crescendo. So the patient may tell you that it kind of started off with a little bit of unease, and then over the next few minutes or over the next hour or so it has reached a peak. So anginal pain can be pretty severe, but it generally doesn't tend to be at crescendo at its onset. So having considered both the quality and the characteristic radiation of the pain, you should also try and see if there are specific precipitating and relieving factors. Now, as far as angina or pain of myocardial origin is concerned, the typical precipitating factors include physical effort and emotion and stress. Sometimes a heavy meal can bring this on. Sometimes even a cold weather, exposure to a cold weather can bring angina on. And these are some of the classical precipitating factors which you might encounter. Now, in considering relieving factors, there are two important factors to consider. One is the obvious one, which is rest. So the patient had performed some exertion, and then when he sat down, the pain felt better. The second important thing is nitrate, and this is important to remember because some of these patients may have a prior history of heart disease, and they might have self-medicated themselves with a sublingual nitrate. And if there is a prompt relief of the pain, especially in a short time like 2 to 10 minutes with either rest or nitrate, that is considered to be classical of angina. Now, the caveat you need to remember here is that in a patient who comes with acute myocardial infarction or an acute coronary syndrome, onset of pain without a specific precipitating factor is definitely a possible scenario, and a lack of relief despite rest can in fact be an ominous sign. So if you're suspecting acute coronary syndrome, it is very possible that the pain may have started off without a specific precipitating factor, and it may not be relieved despite rest. Now, having thought of the classical features of angina, it's also important to kind of remember some of the characteristics which are unlikely to indicate angina. So if you come across these features, it should raise some suspicion that the kind of pain being described may not be anginal pain or may not be the pain of an ACS. And some of these features are the presence of a sharp pain, pain which is particularly worsened in relation to respiration or breathing, pain which is very localizable. The patient is able to kind of point to the finger to a single spot as to, this is where my pain is. Pain which is especially fleeting, it comes in a matter of seconds and then disappears and keeps doing this on and off. Pain which has a postural variation. So the patient says, okay, when I lie down it's worse, or when I adopt a particular posture it's different. If you find specific localized tenderness, which is kind of like an extension of being able to point to a localized spot of pain, or as we discussed before, pain which goes beyond the limits of the typical radiation for angina, such as pain which is radiating below the umbilicus to the lower abdomen, or pain which is even radiating to the lower limb. So these characteristics which are listed here kind of tell you that this pain is unlikely to be anginal pain. The other thing to keep in mind is that classical presentations of angina, if they are present, they are very useful. But in many cases, you will have atypical presentation, or sometimes what we call anginal equivalence. Such atypical presentations are especially more likely to be seen in diabetics, in women, and in elderly people, and we should be more careful in evaluating such kind of people. So some of the anginal equivalents might be the presence of only shoulder or jaw pain without any associated chest pain. They might just come with shortness of breath or dyspnea, again without any chest pain. They could just have non-specific symptoms like profuse sweating, or a non-specific general feeling of uneasiness or unease, something which kind of tells them that something is wrong, and they come into the ER because of that. So we need to watch out for some of these equivalents or atypical presentations. So having talked about the classical features of angina and some of the features which may not be associated with angina, also it's good to keep in mind some of the other classic descriptions of pain which are associated with some alternate diagnosis other than acute coronary syndrome. One of the conditions which can create some kind of confusion, especially in the acute setting, is the diagnosis of acute pericarditis. Now, the pain of pericarditis generally has a different kind of a classical description. It is described as a very sharp pain. It worsens with respiration. It's typically said to be worse on lying down, so the patients feel better on sitting up or leaning forward. And this pain classically radiates to the back, to the trapezius ridge. The background on which a pain of pericarditis might occur, which should make you suspect pericarditis, is a background of infection, especially a viral infection. Another potentially life-threatening cause other than acute coronary syndrome is aortic dissection. Now here, one difference is that patient typically tells you an instantaneous onset of severe pain, where the pain is at peak right at its onset, and they describe it as a kind of a ripping or a tearing pain which is going through to the back. And the background on which this might occur is uncontrolled hypertension. And another acute cause which can constitute an emergency is pulmonary embolism, wherein the patient describes a very sharp pleuritic kind of pain, and usually dyspnea or shortness of breath is a prominent feature. And again, a consideration of the background here might reveal risk factors for venous thromboembolism, such as some kind of prolonged immobilization, such as a lower limb fracture, or intake of drugs which might increase the risk for venous thrombosis, such as oral contraceptive pills. So similarly, in a person coming with chest pain, one needs to consider the overall background upon which these symptoms are occurring. So what are the important features to consider? One is, of course, the age, with older patients definitely being at a greater risk of coronary artery disease and ACS. Then the presence of specific coronary risk factors such as diabetes, hypertension, dyslipidemia, presence of active smoking. presence of prior history of coronary artery disease or a family history of coronary artery disease. And one thing to pay attention is whether the patient has had prior symptoms of angina, and that's important because some of the patients can tell you that I had a myocardial infarction 3 years back and the pain which I'm having today is exactly similar to that, and this is a very valuable point to note in history. Is the symptoms similar or different compared to past anginal episodes? So having gotten a thorough history, the initial evaluation in the emergency room should focus first on the hemodynamic stability of the patient. Now, irrespective of the cause of the chest pain, we need to first see what are the vital signs and whether the patient's blood pressure and cardiorespiratory status is okay to allow a little more detailed or gradual evaluation. Some of the preliminary features which might suggest high risk in this situation is the presence of rest pain exceeding 20 minutes or the presence of hemodynamic instability. So having looked at the general condition of the patient, the second point to think of, especially in thinking of a cardiac source of pain, is to look for whether there are objective signs of cardiac involvement. Now, if these are present, they are high yield because they point you towards a potential cardiac diagnosis. So some of the objective signs of cardiac involvement which might be present include the presence of a third heart sound, presence of basal rulls or signs of congestive heart failure, or an elevated jugular venous pressure. Similarly, presence of certain clues to atherosclerosis might tell you that this patient has a likelihood of coronary artery disease. So one can look for bruits or missing pulses which might indicate the presence of peripheral vascular disease. One should also look for potential clues which might point to an alternate diagnosis, such as a pericardial rub which points towards pericarditis, or presence of unequal pulses which might suggest the presence of an aortic dissection. Now, having looked at the complete clinical picture of the patient in terms of the history and the physical examination, let us consider what investigations would be helpful in sorting out the potential cause of the chest pain. Now, here definitely one of the most important investigations, a simple universally available one, is the electrocardiogram or the ECG. One of the important things here is that if an ACS is suspected, then an ECG needs to be done promptly. So even as you're doing the initial evaluation of the patient, you should simultaneously go ahead and get an ECG, and ideally an ECG should be obtained within 10 minutes of presentation. The way forward, in fact, is that in many places an attempt is made, in fact, to get a pre-hospital ECG. When a patient say comes in an ambulance or a emergency vehicle to the emergency room with a complaint of chest pain, an ideal situation would be to do a ECG even as the patient is en route to the hospital and transmit this ECG to a cardiologist for interpretation, so that any changes of an acute coronary syndrome can be picked up quite early. And an extension of this is the concept of pre-hospital thrombolysis, wherein an ST elevation MI can be diagnosed very quickly even as the patient is being transported to the emergency room, and thrombolysis can be started en route. So while the ECG is a very useful tool to quickly pick up an acute coronary syndrome where classical changes are present, it's important to keep in mind that a normal ECG does not exclude an acute coronary syndrome, and there is something important to bear in mind as we will see later. So the ECG can be a high yield investigation, especially when it shows acute changes, and these changes are especially valuable if we have a prior ECG for comparison and we find that these changes are new in onset, that is, the patient has not had them before, and this is especially valuable. So as far as acute chest pain is concerned, what are the changes which we are thinking in terms of as far as acute presentation is concerned? Now, these essentially boil down to changes of the ST segment and the T wave. Now, new ST deviation, either ST elevation or ST depression, or new T wave inversion, these are valuable. So based on this, the presence of changes in the ECG, you can classify them into high risk, low risk, or intermediate risk. So generally it has been accepted that the presence of an ST deviation exceeding 1 millimeter or T-wave inversion exceeding 2 millimeters is generally considered to be a high risk finding. The low risk situation, of course, would be that there are no ST or T-wave changes at all, essentially a normal ECG. An intermediate risk situation would be the presence of a ST deviation between 0.5 and 1 mm and a T-wave inversion between 1 to 2 millimeters. The other important thing to consider is the concept of dynamic versus static ECG changes. What do we mean by this? What we are trying to say is that if you have ST changes or T-wave changes which are appearing and disappearing as you are observing the patient. So when you do an ECG at onset, and let's say you do an ECG half an hour later or 1 hour later, you find that the ST change either has appeared in a subsequent ECG or the change which was present in an earlier ECG has now resolved. Such kind of dynamic changes are important. They are more likely to indicate ischemia as opposed to fixed changes, especially if we don't know if these changes were present earlier or not. That is why serial assessment is important in a situation, especially where the diagnosis is unclear. Secondly, the presence of changes in anatomically contiguous leads which correspond to a particular coronary territory are more suggestive of ischemia as opposed to changes in an isolated or a single lead. For example, if you find changes in contiguous leads of leads 2, 3 and AVF, then it kind of gives you an indication that there might be an inferior wall ischemia going on. So similarly, in a patient with a normal ECG, if the clinical situation so warrants, you should think of doing both right ventricular and posterior leads if necessary. Otherwise, changes restricted to these leads may potentially be missed. So let's take a look at this ECG and try to answer this question. What do you think this ECG shows? Does it show A, ST depression? Does it show B, ST elevation? Does it in fact show both? Or does it show none of these changes? So if you have a careful look at this ECG, you can see that in fact it shows both. You can see from the leads V1 to V4 and in fact even V5, you can see the significant ST depression which is present. And conversely, in leads 1 and AVL, you can see that there is a more than 1 millimeter ST elevation which is present. And this is something which you find often going hand in hand, just like this ECG shows. You can see the significant ST elevation in leads 2, 3 and AVF, and you can see conversely ST depression in leads 1 and AVL. So what we call reciprocal ST depression often accompanies ischemic ST elevation, and there is something important to keep in mind, because there are some non-ischemic causes of ST elevation which generally wouldn't tend to cause such reciprocal ST depression. Another couple of useful points are ischemic ST elevation generally tends to be up convex or convex upwards, and similarly ischemia related ST depression tends to be either horizontal or downsloping, as opposed to upsloping ST depression, which can potentially be because of causes other than ischemia. Take a look at this ECG. What do you think it shows? You can see here, or you can appreciate from this ECG, that you're having a diffuse kind of ST elevation. If you look at almost all leads, you can see the presence of ST elevation. Secondly, you can also see that as opposed to up convex ST elevation, this is up concave, and this is a feature of pericarditis, and which is why I mentioned before that pericarditis is a potential diagnosis which can be quite confusing in the acute setting, because when you look at ST elevation, obviously the concern is that we should not be missing out on an acute coronary syndrome. So here you need to pay careful attention to the history, wherein the patient may come on a background of infection, may complain of the characteristic sharp pain of pericarditis, and you find this kind of diffuse ST elevation which is not really localized to any anatomic coronary artery territory. Another useful feature which you can find on the ECG of acute pericarditis is what we are pointing to here, is the presence of PR segment depression, and this would also be a useful finding to think in terms of acute pericarditis. Now, having looked at the ECG, one of the second pillars of investigation which helps you deal with making a decision in acute chest pain is the evaluation of cardiac biomarkers. So essentially, cardiac biomarkers are markers of myocardial tissue injury, and the two important ones which are commonly used are the cardiac troponins and the CKMB. Both are essentially cardiac enzymes or markers which are released from the damaged myocardial muscle. CKMB is increasingly being used less frequently now because the cardiac troponins are more specific and false positive elevations of the cardiac troponins are rare. Two potential areas where the cardiac troponin could be elevated in the absence of an ACS include renal failure and sepsis. In most other situations, wherever the troponin is elevated, it does signify true myocardial damage. So if you encounter a situation where the cardiac troponin is elevated, but the clinical picture is not suggestive of an ACS, one needs to consider the possibility that there could be myocardial damage, but due to a cause other than acute coronary syndrome. And some of these potential causes include the presence of generalized hypotension, which will indirectly cause myocardial ischemia, post-cardiopulmonary resuscitation or cardiac massage, or post a DC shock for converting an arrhythmia. All of these can damage the myocardium. Another potential cause is an inflammatory cause such as myocarditis. So all of these can cause elevations in troponin which are not related to an acute coronary syndrome. Just like we mentioned with an ECG, a single biomarker in isolation may not be enough for you to confidently exclude acute coronary syndrome. So it is recommended that in situations where there is a clinical likelihood, you do perform serial biomarker assessments. This is because the biomarkers can take time to be released and get into the circulation and achieve adequate measurable levels. So what is being generally recommended is you do a biomarker level at presentation, and you also do one typically 3 to 6 hours later. Now, a combination of two negative such serial biomarkers, especially with a specific biomarker like cardiac troponin, has a very high negative predictive value. So it kind of tells you that the presence of significant myocardial damage here is pretty unlikely. And now there are newer higher sensitivity troponin assays which are kind of more accurate and may help you to shorten the serial assessment time to 1 or 2 hours rather than 3 to 6 hours. Some of the other biomarkers which have been traditionally used include CKMB, which was more used in the earlier era. One of the limitations of CKMB is that it's less specific because it's produced by organs other than the heart. But one of the potential advantages of CKMB is that it has a more rapid rise and fall compared to cardiac troponin. Therefore, it might be more useful in evaluating a reinfarct, in where a patient who has had a recent infarct and therefore the troponin may still be elevated, but the CKMB would have risen and fallen down, and a repeat rise of CKMB could kind of tell you that there is another ischemic episode which is new. BNP, or brain natriuretic peptide, also rises in myocardial ischemia, and it's released because of an increased ventricular wall stress. But this is not very specific for myocardial ischemia, and in fact it's more often used as a marker of heart failure rather than myocardial ischemia. What are some of the other investigations which might be useful or kind of give you a pointer towards the diagnosis? One investigation which could potentially be performed even in the ER is an echocardiogram. Now, an echocardiogram can kind of tell you two main points. Number one, what is the overall left ventricular systolic function? Is it impaired or is it normal? And another more important finding which you might pick up is what is called regional wall motion abnormality, or RWMA. Now, the presence of motion abnormality in a particular segment, in a particular regional area of the heart, kind of tells you that there is something such as ischemia which is affecting that particular segment of the heart, and therefore it is a high yield finding. Now again, just like with the biomarker, it has a high negative predictive value. especially if you do an echocardiogram during an ongoing episode of chest pain and you don't find any RWMA, it is unlikely that this pain is secondary to ischemia. The presence of RWMA is also useful, but however, just like with an ECG change, we need to evaluate whether this is a new change or it is something which the patient already had earlier. Another common investigation, a chest X-ray, would be less useful as far as diagnosing an ACS is concerned, as the chest X-ray can be completely normal. It may be more useful to point towards alternative diagnosis such as pulmonary pathologies. So, as we discussed, in addition to the clinical picture and the background of the patient, we look at ECGs and we look at biomarkers, both potentially as serial assessments. And then we can kind of put together 4 diagnostic categories based on the clinical picture and the biomarkers. So you could have a situation where the clinical picture is suggestive of ACS and the biomarkers are positive, in which case you then look at the ECG and categorize it as either a STEMI, a ST elevation MI, or a non-STEMI or a non-ST elevation MI. If you have a situation where the clinical picture is positive but the biomarkers are negative, you need to think in terms of a situation of unstable angina where significant myocardial damage has not occurred and the biomarkers are not elevated. If you have a situation where the clinical picture is not suggestive of ACS but the biomarkers are positive, then you need to think whether it still could be a non-ST elevation MI with some kind of an atypical presentation, or whether it's one of the other potential cause of myocardial damage which we discussed earlier, such as the presence of hypotension or a post-CPR situation or a myocarditis. Now the last situation where both the clinical picture and the biomarkers are negative, and here it's worthwhile mentioning again that the assessment should be of a serial ECGs and biomarkers. Here would be the low risk subset where potentially the cause is not related to a acute coronary syndrome. So as far as decision making is concerned, we need to answer one question: what is the likelihood of acute coronary syndrome in this situation? So here again, we should kind of make a construct where we are able to divide into 3 potential risk categories. In a person in whom there are background coronary risk factors, the history is suggestive of ACS, and there are positive investigations in terms of ECG and biomarkers, this is a high-risk subset. You should definitely consider admission and potentially consider early invasive investigations such as a coronary angiogram. In a person where the risk factors are not there are no significant coronary risk factors, the clinical picture is not really suggestive of an acute coronary syndrome, and you have serial investigations which are normal, this is a low risk subset and you might consider discharging home. And if there is a picture in between these two, then that falls into the intermediate risk category, and here is where some more clinical judgment and decision making is required, and you might consider some more further non-invasive testing. Now there have been a number of scores which have incorporated elements of the clinical history, ECG, biomarkers and so forth in order to try and help decision making. Some of these risk scores are risk scores such as the TIMI risk score or the heart risk score, but the basic concept remains the same, that you take a combination of the clinical picture, the risk factor background and the ECGs and biomarkers, and then you make a clinical decision as to which kind of risk category the patient is falling in, and based on that you make your management decision. This is a similar algorithm which is being proposed by the American College of Cardiology and American Heart Association, which kind of gives you an algorithmic approach in order to aid your decision making. So whenever someone comes to you with the symptoms suggestive of acute coronary syndrome, then you have a certain subset where you can say that there is definite ACS going on in terms of the clinical picture and the investigations, and then you go guideline based to manage them as a STEMI or an NSTEMI. Similarly, you would have on the opposite end of the spectrum a set of low risk patients where you are reasonably sure that the pain is not related to a cardiac origin, and here you would treat as indicated by the alternate diagnosis, or if it's a very low risk situation you would consider discharging them home. And in between you have the intermediate risk situation where there is possible acute coronary syndrome, where you suspect it, but you have an initial non-diagnostic ECG or initial normal troponin, and these are the patients who need additional observation with serial ECGs and cardiac enzymes. Now, if the repeated investigations are found to be normal and the background is that of a low clinical risk, you might again consider discharging them home. On the other hand, if the background is not that of a low clinical risk, there is a potential role for additional non-invasive testing in such patients. What are some of the other non-invasive testing which we can consider in a subacute kind of a situation? One of them is to perform an exercise stress test or a treadmill test. Now, this might help clarify a picture in a patient with some kind of a slightly atypical presentation where serial ECGs and enzymes are normal. You have to bear in mind that you should have at least 2 biomarkers negative before putting a patient through a stress, because it's not a good idea to put a patient who might be having an ongoing acute coronary stress syndrome through a treadmill stress test. Similarly, clinically you should not do it if the patient has active ongoing chest pain. Another potentially useful investigation with a little higher sensitivity is a stress echocardiogram, wherein you can use a pharmacological stressor such as dobutamine and look for the development of new regional wall motion abnormalities. Similarly, nuclear imaging such as SPECT is useful because it can actually give you the regional perfusion in the acute situation and help you to decide if there is evidence of ischemia or not. Another investigation which is being recently being increasingly used is a coronary CT angiogram, and this can especially be useful in intermediate risk situations because it can lay out the coronary anatomy with a good degree of accuracy. Now again, this will have a good negative predictive value because in a patient with suspected ischemic pain, if your coronary CT angiogram is completely normal, then automatically the patient comes into a low risk subset. And studies have shown that this approach has been helpful to more confidently discharge patients home with a low likelihood of ACS. Lastly, I would like to introduce the concept of the chest pain unit, which is being increasingly implemented in a number of centers. The idea is to have a dedicated evaluation unit with protocol-driven management. So the dedicated CPUs essentially incorporate a process flow of management, a systematic protocol-based approach, wherein you help to identify the high-risk patients quickly and at the same time avoid unnecessary over-investigation of those potentially at low risk. So it helps more effective triage into high, low or intermediate risk so that there can be expedited admission into CCU for potentially high-risk patients and also expedite early non-invasive testing. So having kind of gotten through an overview of how to deal with the acute onset of chest pain with a specific emphasis on acute coronary syndrome, let's get back to our case scenarios which we had started with. So we talked about the first case where we have a middle-aged gentleman, a diabetic and a smoker who comes to you with the kind of ill-localized chest uneasiness. And we asked the question, which of the following tests can help rule out an acute coronary syndrome in this patient? So what do you think your answer should be in this situation? Well, it is not really any of these investigations which can rule out an ACS. The learning point from this question is that no single investigation can effectively rule out ACS. One needs to consider the overall picture and one needs to consider serial assessments as well. So in this person who is middle-aged, has coronary risk factors and who is having a pain which is quite suggestive of angina, one should be very wary of ruling out ACS based on a single normal ECG or a single normal troponin level. Let's look at the second case which we had talked about. This is a relatively young gentleman, a college student, a 20-year-old, who comes to you with a sharp, localized kind of chest pain which is varying both with posture as well as with respiration. And we ask the question, as to which of these features would support acute coronary syndrome as the likely source of pain. So if we look at the possible choices given here, one can see that the presence of associated autonomic symptoms such as nausea or vomiting is what is most suggestive of anginal pain. Whereas in this particular case, where you have postural variation of chest pain, that is much more indicative of alternative causes such as a pleuritic chest pain or a gastroesophageal reflux disease. And similarly, pain radiating to the trapezius ridge is more characteristic of pericarditis rather than angina. And lastly, chest pain which is specifically relieved on exertion, specifically relieved on walking, is very unlikely in a situation of acute coronary syndrome. Patients with a ongoing acute coronary syndrome chest pain would be very reluctant to engage in any kind of stress. So to wrap up, let's talk about one more potential case scenario, and this is a real life case scenario which has actually been encountered in the ER. So this is a 41-year-old premenopausal woman with no known coronary risk factors. She developed severe chest pain just 5 minutes ago, and it so happened that they were passing by close to the hospital, and therefore she was brought straight into the emergency room within 5 minutes of chest pain onset. She had just had an argument with her husband, and the husband states that she is generally an anxious type of woman and is prone to hysterical attacks. On examination, she appears pretty restless. She's complaining of pain. Her vitals are pretty stable. You perform a thorough examination and you have a completely normal cardiovascular and respiratory examination. Her ECG and spot troponin is completely normal. Now we have spot troponin tests, which can instantaneously give you a result by the bedside, and these are useful because they help you to cut down the time waiting for the investigation result. So this is the scenario of a completely normal examination, and ECG and spot troponin is totally normal. So which of the following would be an appropriate next step in this patient? Would you, as the treating physician, give an analgesic and an anxiolytic and send the patient home? Would you admit her straight away to the intensive coronary care unit? Do you think you should perform a treadmill test? Or you should repeat a ECG and a cardiac enzyme? While you chew over this question, let me tell you what actually happened in this real life scenario. Considering the patient's age, gender, she's a 41-year-old premenopausal woman, and lack of risk factors, the ER resident discharged her home with analgesics and sedatives. The next day, the patient was back in the ER, and this time not with chest pain, but with severe shortness of breath and low blood pressure, looking very sick. And this is what the ECG showed the next day. Can you interpret this ECG? You can look at it and you can see that there is extensive Q waves all along the anterolateral leads, and there is ST elevation which is kind of now settling down and going into T wave inversion. This is a fully evolved anterior wall MI, and the patient has now come with severe heart failure. This is really a large missed opportunity. So when we said which of the following is appropriate, one needs to keep in mind what we said right at the beginning, that a single investigation should never be taken as proof conclusive of an acute coronary syndrome being ruled out. So really here, rather than being influenced by subjective factors of whether the patient is an anxious type or not, a protocol-driven approach should have been taken, and the ECG and the cardiac enzyme should have been repeated. If the ECG had been repeated in something like 30 minutes, this is probably the picture which would have been seen. So it's worthwhile remembering that in patients who come very quickly after the onset of an ACS, the initial ECG can be completely normal, and so can the initial cardiac marker, because these take time to become abnormal. So an additional final note of caution is to keep in mind that in recent years the epidemiology of both coronary artery disease as well as acute coronary syndrome is changing. So premenopausal women can have a myocardial infarction, they can have an extensive STEMI, and in fact studies have shown that such premenopausal women and women in general have a worse prognosis because they are more likely to be underdiagnosed and treatment is more likely to be delayed. So it's important to bear in mind the concept of a protocol-based approach and to keep in mind that a single normal ECG cannot rule out a serious life-threatening ACS. Thank you for your attention.